Okay, so let's talk about another rhythm called atrial fibrillation. Remember, these rhythms are not originating from the SA node. So we can't call them normal sinus rhythm, and they're not following the normal pathway from the SA node to the atrium, to the AV node, and then to the ventricle. Okay, so they're going to look different. Atrial fibrillation is a condition where the atrium is usually you have an enlarged atrium. Typically, it's the left atrium from congestive heart failure, and the left atriums become distended and enlarged, and that stretches the nerve fibers of the atrium, and they become really irritable, and they start to release a lot of electrical activity from the atrial nerve fibers. So um, and they're fibrillating. What does that mean? Well, because all of these little areas of nerve fibers in the atrium are sending out their own signals, there's not going to be a P wave, by the way, because the P wave would have come if you had a signal from the SA node. In atrial fibrillation, these areas of the atrium are firing all at the same time, very, very fast, because the atrium is irritated, typically from being enlarged. So there's nothing coordinated about it. So we're going to get an irregular rhythm. Why is the rhythm irregular? Well, the atrium might be firing, so depolarizing at 300, 400, 500 um, per minute, but that's not your heart rate. Remember, your heart rate is coming from your QRS. Okay. So what's deciding the heart rate is the AV node. How many of those beats is the AV node allowing to get through to the ventricle? If it's allowing many beats to get through, you're going to have a very fast heart rate. So it's going to be atrial fibrillation with tachycardia. If it's only allowing 60 to 100, it's just going to be atrial fibrillation, but not tachycardic. Okay, so what does atrial fibrillation look like? It's irregular because the AV node is only allowing certain of the electrical beats or electrical signals from the atrium to get through. So it's an irregular rhythm with irregular distances between the QRSs because the AV node is deciding which ones to let through and which ones not to let through. And what else about it? There's no P waves. There's no consistent P waves at all. So it's an irregular rhythm and there's no P waves. Okay? So what can we do about this rhythm? Well, a lot of people don't feel great in atrial fibrillation. It's the atrium aren't contracting like they normally do, and they can feel that their heart rate's irregular. So they don't feel great in it, so we can try and get them out of this rhythm. If they've only been in this rhythm for 48 hours or less, we can try and get them out of this rhythm by using electricity, so cardioversion. So we can sedate them, we can give them something for pain because electricity hurts, and we can cardiovert them. We can reset the electricity of the heart to see if it goes back to normal sinus rhythm. Okay? So that's one option. The reason it's less than 48 hours is if someone's been in atrial fibrillation for longer than 48 hours, there's a risk that they have some clotted blood in their atrium. And if we convert them to normal sinus rhythm, it could throw off that clot and cause a stroke. Okay. So what else can we do? Well, we could use a beta blocker to slow them down. We could use a calcium channel blocker, to slow down the heart rate. Okay, calcium channel blockers and beta blockers block the AV node a bit, and it'll slow down the number of QRSs that are getting through. Okay, it's stopping some of the impulses from getting through the AV node. So that's another treatment we can use. And we do that all the time with atrial fibrillation. We give them a beta blocker or a calcium channel blocker such as diltiazem to slow down the heart rate if they're going too fast. Now, in terms of if they come in with atrial fibrillation and they're beating really fast, say a heart rate of 180, and they're unstable with low blood pressure or chest pain or decreased level of consciousness, any time that someone has a rhythm that's causing them to be unstable in terms of vital signs or decreased level of consciousness, we just go right to electricity. Okay, so any instability equals electricity to get them out of the rhythm. And with atrial fibrillation, even if it's been a week of atrial fibrillation, we accept the risk of the blood clot traveling because they're unstable. We need to get them out of the rhythm. Okay. What about long term? So long-term treatment, patients with atrial fibrillation are typically on an anticoagulant, such as warfarin or Coumadin. Or we can use another anticoagulant as treatment, such as heparin. Coumadin doesn't work right away, so often we have to give them heparin, which works right away, and then we start the Coumadin and we wait until the Coumadin or warfarin is therapeutic, meaning an INR between 2 to 3, and then we can stop the heparin and continue them on the warfarin. Okay, there's newer agents that work right away, right, such as rivaroxaban or apixaban. Those are anticoagulants that work right away, and we don't need to bridge patients with warfarin. We can just start them on it, and that's their anticoagulant. Okay. Sometimes we can control patients from going back into atrial fibrillation by giving them an antiarrhythmic, such as amiodarone, which tries to settle the irritated nerves in the atrium and stops the atrium from going back into atrial fibrillation. Okay. And lastly, they can go for an electrophysiological study, an EPS study, and they can look at the nerves of the atrium and burn the ones, meaning ablate the nerves that are causing the atrial fibrillation. Okay, so typically patients that have atrial fibrillation are on long-term anticoagulants, and if we can't get them out of atrial fibrillation, then we keep them on anticoagulants and we at least slow down the heart rate with either metoprolol, which is a beta blocker, or diltiazem, which is a calcium channel blocker. Okay? Always remember, an unstable rhythm, any rhythm that's causing instability, such as low blood pressure, decreased level of consciousness, chest pain, we just go right to electricity. Now, if someone comes in atrial fibrillation and they've been in it for a long time, say 5 days or a week or 2 weeks, we put them on an anticoagulant. We slow down their heart rate with metoprolol or diltiazem, and then we can schedule them after they've been on an anticoagulant such as warfarin for 6 weeks. We schedule them for an elective cardioversion where they come back, we sedate them, we give them pain medication, and we perform an electrical cardioversion to see if we can get them out of this rhythm. Okay, so let's look at another rhythm coming from the atrium, which is called atrial flutter. And basically what's happening in this rhythm is there's an electrical circuit in the atrium that's circular in nature, and it's just going round and round and round the atrium, typically at around 300 beats per minute of the atrium, not the ventricle. So that's where you're going to see those P-like looking waves. Many of them going right across the rhythm strip. So atrial flutter is basically just a circuit of electricity that's stuck in the atrium. It's going round and round. Now, what decides the rate, the heart rate? Well, that's the AV node again, right? So the AV node isn't going to allow 300 signals from the atrium to get through to the ventricle. That's too fast. It doesn't want to allow that much. So it's going to block many of them. So when you look at the rhythm at the top, you're going to see that some of the QRSs are getting through, but many aren't. Okay? So this is a very similar rhythm to atrial fibrillation. Okay? They're almost like cousins of each other, except this one, the atria are fluttering at a rate of around 300 per minute, whereas atrial fibrillation, there's just firing from multiple different sites in the atrium. Okay? So this one has a very distinctive appearance. It has what we call a sawtooth appearance, which is those P-like looking waves, which are coming from atrial depolarization. They're not coming from the SA node. Okay? The SA node would never fire at 300 beats per minute. Okay, so, and is there a QRS after every P wave? No. So very distinctive appearance of atrial flutter. They can sometimes be regular QRSs, meaning the AV node is letting, say, 150 of them through out of 300. So it would be what we call a 2-to-1 block, meaning every second beat from the atrium will be allowed to come through. So it can be regular or it can be irregular. It has that classic sawtooth appearance. And the heart rate depends on how many electrical signals the AV node lets through. So it could be going at 150. It could be going faster. So it just depends on the AV node. So what's the treatment for this? Well, if someone comes in an atrial flutter, we could certainly try a vagal maneuver to see if it'll break this rhythm. Often it doesn't. Okay. We could slow down the heart rate if it's going fast. So atrial flutter with tachycardia with a beta blocker or a calcium channel blocker. That'll slow down conduction through the AV node and control the heart rate. If it's unstable, so say someone comes in and they have atrial flutter suddenly and their blood pressure is 80, well, we don't give them drugs at all. We just go right to electrical cardioversion, right? Unstable rhythm equals electrical cardioversion. Okay, so atrial flutter has the typical sawtooth pattern. The AV node is deciding how many of the electrical beats from the atrium are allowed into the ventricle, and that'll determine the heart rate. Okay, so the top two rhythm strips are atrial flutter, just in different rhythm strips. That's all, different rhythm strips from the monitor, and the bottom is normal sinus rhythm. Now, the other thing is we often put people on anticoagulants for atrial flutter. I mentioned that atrial flutter is similar to atrial fibrillation. So often people have atrial flutter and atrial fibrillation throughout the day. So they're kind of close cousins, okay? So often we'll give them anticoagulants because of the risk of forming a clot within the atrium. Okay, so we've spoken about rhythms going down the normal nerve pathway. So normal sinus rhythm, okay, that's totally normal. Sinus tachycardia, sinus bradycardia. We've spoken about two rhythms from the atrium, atrial fibrillation and atrial flutter, and we've spoken about a fast rhythm that originates within the AV node called supraventricular tachycardia. Let's just talk about extra beats, something that we call premature beats. So it's when either the atrium or the ventricle, one of them, wants to just send off its own beat. Okay, and they're usually quite harmless. So let's look at the first one. So a premature atrial complex. So if you look at the rhythm strip on the right beside a PAC, you'll see, especially towards the end of it, that it's just normal sinus rhythm. There's a P, a QRS, a P, a QRS. Okay, let's go to the beginning. So the first beat is a P and a QRS, and then you have this really odd looking little P and then the QRS. That's called a premature atrial complex. It's just where the atrium has created its own little beat, and sent it down to the AV node, and it got conducted and developed a QRS. Okay, and you can see two of them that are circled there. How do we know those are PACs? The P waves look totally different. Okay, so they're just premature atrial complexes. Let's just say the atrium got a bit jealous. It's tired of the SA node taking all the glory, and the atrium has sent off its own extra beat. They're harmless, nothing to do. Okay? Okay, let's look at the one on the bottom, a premature ventricular complex. So people can get premature ventricular complexes where the actual rhythm here is normal sinus rhythm. Okay, so let's look at the rhythm. So there's a P, QRS, P, QRS, P, QRS, and then this wide, abnormal looking beat. That's a beat that's come from the ventricle itself. Okay, so the ventricle said, you know what? I want to send off an extra beat, and when it does so, it's called a premature ventricular complex, and there's usually one or two of them. They're usually quite harmless. If people have many of them and they're symptomatic with PVCs, then sometimes we'll use an antiarrhythmic to just settle down the frequency of the PVCs. Okay? But in general, the occasional PVC is really quite harmless. Okay? But some people come in and say, you know, every couple of seconds I'm getting extra beats and I don't feel good. It feels my chest is going to jump, or my heart's going to jump out of my chest. And we can try an antiarrhythmic or sometimes even a beta blocker just to settle down the ventricle and stop it from sending out extra beats. Okay. So you're going to notice that the PVC is actually quite wide, right? It's widened. So in terms of time, it takes a long time. And why is that? Because the PVC started in one part of the ventricle and it didn't use those fast nerve bundles. So it has to go from myocardial cell to myocardial cell and depolarize the whole ventricle, but it takes longer, and that's why it's a wide complex. Compared to a premature atrial complex that starts in the atrium, but then goes to the AV node and uses the fast nerve bundles. So there's a narrow QRS complex. Okay? Okay, we'll move on here.